Friend?
Mr. Othercrow?
Absolutely.
Okay.
That is all of his blood sugar vitals, etc., from when you discharged him until today. What we've kind of noticed is some maybe 3 to 5 days into when he was discharged, and probably even previous, he's channeled, his blood sugar is channeled from in 100s to 200s pre and post meal, up to in the morning pre-meal 200s, spiking up to 300s. There have been a couple of times when we've noticed spikes into the 400s, low 400s. Yeah, there that is. And the highlighted ones are all figures that are reflective of above 200.
So no pulses that were real low this time, huh?
No, once he came out, he's been above 50s, 60s, mostly 60s, 70s. Temperature has been excellent. We're keeping him, we're more conscious of getting water in him. I am there in the nighttime shift from 3 to 7, and I am making sure that he eats what I cook. So I'm getting food in him, even if I have to put it in his mouth myself. We are, because he eats on his own breakfast, we've gotten to the point where we feed him a breakfast in the morning, and I'll actually feed him a couple of eggs and bacon and sausage or sausage at night. The new pill, we're just, from our observations, we're sensing that the pill fights the breakfast meal in the morning, and then we're more vulnerable to Dad's blood sugar spikes starting about 12 on into the supper time, thinking that the pill's efficacy, I guess, has subsided. Its potency is more in the morning when you take it, and we have to be more concerned about what he eats at lunch and supper than we did in what he ate in the breakfast time. Is that generally kind of...
He's on a low dose of it.
Okay.
So we can certainly adjust that.
Yeah, that would be good. What would you say his target pre-meal and post-meal ought to be that we should be targeting?
Well, he's 92 years old.
All right.
We're not going to prevent long-term damage from diabetes, because there is no long-term
Absolutely
in the future at this point. So I'd say we don't want his blood sugar getting down below about 80, and we probably don't want it higher than 300.
Okay. We're starting to use, and I brought the meters. There's a Bayer meter that allows a computer connection, and I'm going to start saving those. Do you allow correspondence via email, Dr. Kulback?
No.
Okay.
So I don't check it off, and I don't have the chance to check it off enough to be relevant if someone's having a real problem.
Gotcha.
A phone call to the office, and we take care of messages quickly, same day.
Here's one thing that has helped us tremendously through this process is y'all's home care arm. We were introduced to it through Dad's catheter, through Dr. Cox. And yesterday I had a great conversation with Tim Bentley over there. I was talking to him about Dad's diabetes situation. One thing he suggested is that they do have what they call a diabetes training program, in just opening up an avenue so they can begin to monitor Dad's diabetes with us. Is there a possibility that you could order that training to open up that avenue through home care?
Who's going to get trained?
All of the relatives. We're talking about nutrition, those kinds of things.
Usually that's for the patient, and he's not really going to benefit.
Right. I mean, we are his patient, basically. I mean, we are his eyes and hands.
Well, I understand the care, but I'm not sure how that works with training caregivers if Medicare pays for that.
Right.
I mean, we can order it, but if you had to pay for it yourself, would you want to do it?
Yeah, let's order it and just see where it might go.
The thing is, to get home health care, you have to have the need for a skilled nurse, and it's for a limited period of time.
Right.
Now, I don't think he needs or would benefit from physical therapy. We did that already.
Right.
There's not any additional advantage to be gained from that. If he doesn't have the catheter care anymore.
And he does. He's still got that.
That was ordered by Dr. Cox. And
Absolutely.
By him.
Right.
We could certainly, the diabetes education classes are for the patients too. I don't think over in the hospital, I don't think that they would, you could pay for it yourself, but I don't think any insurance would pay for family members without the patient being the one involved. Right. Getting diabetes education. I'm not sure how much education needs to be done. You're doing a whale of a job.
Right.
Here. Data is great. That tells me a lot, and I like seeing that, so I appreciate you bringing that in.
Right.
I think we need to go up to 100 milligrams on the Januvia.
Okay. How about
which is the normal dose.
How about an afternoon pill if Januvia?
No, I don't think so. Again, we're not trying to keep his blood sugar at 110 and strict control on him, because all we're trying to do is keep him regulated well enough it doesn't cause him any symptoms.
Bingo.
We're not looking for the long-term benefit of
Absolutely.
preventing microvascular disease to the kidneys and the nerves.
Right. We want general equilibrium of health.
He doesn't have long enough left to
Absolutely.
to have that make a difference.
Right. Here's another thing that we were wondering about.
It faxed me over some stuff from the home health yesterday, just to sign all this. And there's like 2 pages of stuff, and I said, but I had him fax it back. What is the skilled nursing need that he would benefit from? So I haven't heard back from him. Here's what
I think they did is that they lost sight of the fact that Dr. Cox had opened up the original requirement for home care. And then I said that you were their primary care physician, and I think that they just started sending it out to everybody. Since then, I've talked to Dr. Cox's nurse, and she says, she gave me the fax number and said, yeah, we'll sign him up, reauthorize him for catheter management.
Yeah, absolutely.
So they got all that information now, so I suspect that.
It's amazing. I'll have a patient that I didn't even know was in a nursing home. They'll get discharged from therapy, say they had knee surgery or something, went to a nursing home for rehab. They get discharged from there by the nursing home doctor, and all of a sudden I've got 5 pages of home health care orders that they want me to sign. I don't even know what the heck's going on.
Gotcha.
Just because I'm the primary care doctor, I haven't heard a thing from the knee surgeon. I haven't heard a thing from the rehab doctor at the nursing home. It just shows up on my desk. I say, well, what the heck's going on?
Right.
And I don't like to sign things when I don't even know what the reason for signing them is.
Absolutely. So right now he's on 50 milligrams of Januva?
Yeah, Januvia. We'll bump that up to 100.
Okay.
And again, I'm not shooting for tight control on diabetes on him.
Correct.
I just don't want his sugar to get up to 400 and start causing symptoms.
Yeah, what we're noticing when he gets into the high 300s, he's more unresponsive, more tired. He's not himself. And we're trying to get, ideally, we'd like to get the relatively old dad back at least through his expiration, if you understand what I'm saying. This morning he was,
Heart rhythm was nice and steady.
his blood sugar this morning was 228, blood pressure 128/66, pulse 82 this morning.
All that's good.
Yep. He had a bowl of cereal, a little milk on it, and we gave him about 8 ounces of water. Where do you think, if we're at home, and let's say we've established our great arm into home care, and so we're able to get on the phone with our nurses, and they've been able to help us triage the state of Dad. Matter of fact, the last time Dad came into the hospital, he wouldn't have come in probably unless their nurse had come by. I had asked that the nurse come by, and he encouraged me or instructed me to put Dad in the car and take him down because of the 29 pulse, et cetera, et cetera.
Right. But now you're watching that pretty close yourself now.
Right, exactly.
The pulse, and that could happen any time again.
Right.
He could go into complete heart block. And,
Right. If we've got these vitals and we're producing these vitals, where would you suggest that we should be alarmed and take action? Like, when should we call home care and have them kind of begin to beat with our eyes and hands?
Heart rate's 28 or 30.
So the pulse at 30.
I mean, if it's less than 40, I'd be alarmed.
Okay, less than 40.
If his pulse is greater than 40 and his blood pressure is okay, I'd just kind of watch that.
And what would you consider acceptable blood pressure?
All these are fine. I mean, if his blood pressure drops to where it's so low that he's not responding, let's say less than 90,
90 on the top?
Yeah. Or if it stays up like 190 or 200 on the top, I'd be worried. That's way too high.
Gotcha.
It doesn't look like that's a danger. All these blood pressures are in
Right.
much better range than that.
How about the below number? Is there any concern about the below number?
No, not too much.
Okay.
I don't think I'd focus on that. I mean, it's an important number too, but in this situation, not so much.
Okay. What we're trying to do, I think you kind of understand what we're trying to do, is we're trying to keep Dad out of the hospital. The more times we can manage all of this process at home, keep him at a level of equilibrium at home, the better off we are. And the better off he is. One of the things I noticed about Januvia when I was reading about it is sometimes they marry it with metformin. What's your thoughts on the metformin?
Metformin, it's good too, but no sense giving two drugs if one does the job.
Absolutely.
Metformin, you got to be careful if the kidney function is diminished. You don't want to give it with decreased kidney function.
So are you thinking that hopefully with the 100 milligram that we will begin to see him wake up within the hundreds, and then after the meal roll into 200s?
You don't usually get hypoglycemia with Januvia, so I'd expect it to be in the low to mid hundreds, and occasional ones over 200.
Gotcha.
But hopefully none of them over 300. He had a couple of them like that on that.
Right.
Okay, let's see.
He takes this pill, Januvia, in the morning with the meal, either before or after the meal. I assume that's okay. Okay. They take these blood sugar samples before he eats, before he actually gets up.
Fasting before?
Yep.
That's good. That's
Absolutely.
what you're supposed to do.
and then we're going to try to get her to take a snapshot of blood sugar right before she gives him lunch. Then he'll have lunch, probably take a nap. I come in at 3, and I'll take a snapshot before I feed him at supper time, and I'll probably take a snapshot. How long should we wait after he eats to get a good post-meal reading on blood sugar?
Hour or two, but I would only do that once or twice a week. You don't need to do
Gotcha.
that regularly.
Okay.
The fasting one's the more valuable one, and then once or twice a week, hour or two after a meal in the evening or something like that.
Got you.
Okay, you're still on the Namenda for the Alzheimer's, right?
Yep. Enalapril, Amenda. I think you put him on enalapril twice a day. You went back to twice a day on enalapril. We give him, he takes the Flomax and I think enalapril for at night.
And you know, the Flomax, if he doesn't ever get the catheter out, the Flomax is redundant.
Right, right. It's just kind of crossing our fingers, wishful thinking. We got another window with, on January 9th, we're going back to Dr. Cox.
Okay.
And it may be about January 9th that it's time to Dad to change his catheter anyway. So home care is going to come in, probably take it out in the morning. I take him down to the doctor, and then either they put it back in or home care puts it back in. I'll say this, Dr. Kulback, your home care group
It's really
is the best thing y'all did.
Well, it's actually not. I have nothing to do with it. It's
Yeah.
an independent agency.
Yeah.
And
It's a great arm, though, for
St. Vincent's.
to transition and allow information about what's happening in the home to feed back up to y'all. Where a lot of times when people probably walk out of your office, you are not getting this. You probably don't get hardly anything.
I do better getting the information from you than I do from them.
Gotcha.
Actually, home health care nurses have very poor.
Really?
I mean, they do a good job in the home, but as far as giving the doctor useful information,
Right.
not much.
I think-
Sometimes they'll draw protimes, they do the blood, but then they get the protimes to us at a time that's really not, I mean, they need that right away, and it may be days before we get it sometimes. It's real variable. I've got mixed feelings about it. I think a lot of times they go into the house when I need them to do speech therapy. The next thing I know, they've got a list of about 15 different things that they want to do that I didn't order, but they want to have me sign for it because then they can bill Medicare and get a lot more money for doing it.
Yeah, it's a financial
A lot of times
incentive.
it's very cursory, and they claim they do all this training, but when I talk to the patient, they're not really doing any training, and it may be somebody like him that isn't going to remember anything, or somebody
Right.
that's already very well educated about the diabetes. They don't need additional diabetes
Right.
training from a nurse at home, but they still want to do that and have me order it because they can bill the government and get money for it. So I've got mixed feelings. I think they can be very,
Yeah.
very helpful at times. Other times I think they're milking the system.
Here's another thing that I found when talking to Tim that is good about this group is that, number one, they have a kind of a whole person mentality, state of health mentality, and for example, y'all have got a hospice arm in that group as well.
Right?
So whatever information is gathered within the home care gets transitioned to hospice. So they learn about Dad's diabetes. They learn about his catheter. They know, the nurses know Dad. It helps us triage as non-medical people. If I hadn't had Darren come in there, I would have not known how bad Dad was to even know to bring him down to ER. To me, that's where it's a wonderful blanket of support for people that are non-medical.
Well, that's good. I'm glad, I mean, in this case and in your case, I'm glad that it's really working out.
Yeah.
That's the way it's supposed to work. Doesn't always work that way.
Right.
That's the way it's supposed to work. Well, let's check his blood chemistries today
Okay.
and his kidney function and see how well hydrated he is.
That would be great to
Bring me
know.
another one of those when he comes back. next time.
Absolutely, I will.
It's very helpful. I like seeing that.
Absolutely.
Information.
If you if you wanted it electronically by that time, I'll have it to where I got to upload it to you.
I don't have a way to put it into my notes.
Gotcha.
I still will have to. It's easier if you bring it on the paper because I
Gotcha.
can look at it and put selected information into my notes versus having to put it into a computer, download it, and then try to sort out what I need to put
Right.
in my notes.
Is there a particular format
That's
that
good.
is that all right?
That's very good.
Okay.
Just a spreadsheet.
All right.
Like that's very good. All right, we'll wait here and I'll have Angela get you'll check out and we draw the blood here. You don't have to go downstairs anymore.
Good.
And I want to see him back in 2 months.
Okay.
Push it out a little bit further this time.
And basically, if he gets beyond down below 80 or 300 or these thresholds, then we should be calling home care or y'all or
Yeah, either way.
okay.
And
Can I get you to order that home care just so I could have a conversation with Tim to try to understand what they can bring to us from a nutrition perspective so they can help us a bit?
I got to see they'll fax it. Hopefully they'll fax back the reason for the visit and everything for me to sign.
Okay.
Not add in 30 other things
Okay.
that they want to do that won't be helpful.
So you're looking for them to fax you something to
They have
suggest to
orders.
you. Order.
Of
Okay.
what they can do
Very good.
that a skilled nursing need.
Absolutely.
I mean, you can't just have someone come in
Absolutely.
if there's not a skilled nursing need for that patient. Now, the skilled nursing need is for the
Catheter.
catheter thing is one thing, and if they're already ordering that from Dr. Cox, then that's probably all that's going to need to be done. I mean, they can add on to that whatever else they're doing, but if they want something specifically from me, they need to spell out what it is,
Okay.
and not just send me the whole battery of things that they can do.
Gotcha. Very good. Thanks, buddy.
Wait right here. Good to see you, Mr. Crowe.
One other question here.
I'm amazed how well you're doing.
How about these monitors right here, the ones we've used here? There's a True Track. Can y'all do any testing, calibration, or anything like that with any of these?
We don't have any equipment to do that.
I got you.
And those things aren't 100% accurate. You know, they're accurate within about 10%
Right.
of what. So there's a plus or minus 10% of his blood sugars. 220 on that thing, it might be 220 plus or minus 22.
Got you.
You know.
These blood statistics that you're fixing to acquire, will we get a sheet so we'll know what the lab said his blood sugar
Mail a
was?
little card with the results on it to the house. Now,
Perfect.
This is Christmas.
Yes.
The mail's slowed
Yep.
down. People are out of the office. It may take a little longer than usual.
Yeah.
It's usually within 3 or 4 days, but
Do you have to request it, or do they do that automatically?
no, I actually fill it out, put the results on a card myself and send it to you.
Wonderful. Thank you, Kulback.
Good to see you.
Appreciate it. That was good. Stay where you are. They're going to come and get you and get blood for you.